And you all can hear me?
Yes, yes.
Okay,
Yes.
wonderful. So because we have such a good panel, I'm going to focus on pelvic metastatic disease and minimally invasive pelvic metastatic disease. We'll touch on the hybrid approaches that we've developed, and we'll talk about the structural approach that needs to be used and thought about when tackling pelvic metastatic disease, guidance techniques, and some outcomes. So the scope of the problem continues to get larger and larger, and so as patients are living longer and longer with their cancer, which is a good situation, the therapies that we are using to treat them, the chemotherapies, the immunotherapies, bone marrow transplantation, all of those are having a significant effect on the skeleton. And so as you can see in this table, compared to men and perimenopausal women who lose 0.5 to 2% of their bone mass year over year, it can be as high as 8% per year. So that's a very significant problem. It leads to catastrophic fractures and debilitating loss of function and pain. And you can see two patients that had sacral fractures in the setting of cancer and cancer therapy here. And so that is the background. And so we're seeing more and more patients in our clinics with both the complications of their therapies, but also metastatic disease. Behind the spine, which my colleagues will talk about, the pelvis is the most common location for pelvic mets. And as you can see in these examples, it can present in a varied way. So you can have blastic disease, you can have lytic disease where the cortex is primarily intact, and you can have progressive lytic disease and destruction of the cortex with the medial wall being violated. And in the last example where you have the lateral and medial wall violated. And so we need to think about all of these patients differently. So one therapy for somebody who has pure blastic disease is not going to be this appropriate for somebody who has this catastrophic metastasis on the right-hand side of your screen. So we have a team at the Medical College of Wisconsin that includes my new partner, Brandon Key, and then our orthopedic colleagues, and we team up. We have multidisciplinary conferences every week. We do surgical and interventional planning where we couple ablation, embolization, and some of these structural therapies that we'll talk about, and we're really seeing improvement in our patients. So when we're looking at these patients, we need to think about their cancer, but we also need to think about the effect of the cancer on the patient, their pain, their instability, and the things that we can offer for those patients. And so for disease control, we can offer ablation, arterial embolization. We can have the patients get radiation and systemic therapy or send them on to surgical resection. When it comes to the pain and instability, we can offer simple osteoplasty or vertebral augmentation in the setting of spine disease, or we can do a combination therapy of screw fixation plus osteoplasty, or we can do formal surgical stabilization. The problem is that these patients need to stay on their chemotherapy and radiation. This patient who had a significant, total hip replacement for metastatic disease, is going to need to have a significant surgery, is going to have extensive rehabilitation, is going to be delayed to have their chemotherapy and radiation for as much as 8 weeks. And this surgery actually has significant complications, including death, infection, bleeding, hardware failure, just to name a few. A number of centers and authors, including our center, have tackled this. And so I'm happy to say that there are multiple centers in Asia, in the United States, and in Europe that are tackling this problem, looking at combinations of ablation plus osteoplasty, combinations of ablation plus osteoplasty and fixation with hardware. And so when we look at the patients that we talked about earlier, the patient on the left, probably given the intact cortex, could maybe just have ablation alone. Whereas this patient just to the right here, who has a very lytic lesion, probably needs to have ablation plus osteoplasty to prevent fracture. And finally, these two more extreme examples, will likely need to have either surgery or ablation plus a stabilization procedure, including hardware, including screws. This has been reviewed, and there's a sort of a thoughtful approach to this. Joe Lane at the Hospital for Special Surgery in New York City wrote a review kind of looking at the progression of disease. And so you can see that if you have an isolated dome lesion, that's a relatively low risk situation. As we involve the medial wall, it becomes more dramatic. As we involve the posterior column and the potential for fracture posteriorly, this is a more severe situation, and the worst being the type 4 or type E, which is where we have both posterior column and anterior column involvement. And so basically you have to fit the therapy to the level of involvement in the acetabulum. So in those patients that are more minor, that have really just simple either blastic lesions or relatively minor lytic lesions, we can offer ablation plus cementoplasty, and our colleagues in Asia have reported on this. We have a number of reports out there where patients are getting osteoplasty. They have relatively low risk lesions, and they're having significant improvement in their pain. And you can see just examples of where simple osteoplasty is a nice technique, relatively straightforward, and can be done as an outpatient. We've actually looked at this and tried to kind of study the load, and we created a phantom, created this lesion in the acetabulum, and then we've looked at loading these to failure. And so this is a mechanical model that we use, a benchtop model, and this is the failure force required for the untreated. If you just use screws, you gain a little bit. If you use cement, you actually gain quite a bit, but the strongest construct is in fact screws plus cement, which is the phantom you can see here under X-ray, where we have screws, ischial screw and a ilial screw plus cement augmentation supporting the acetabulum, and this gives us the strongest construct. And this is the rebar like we have in our highways that gives us that strongest resistance to different types of forces that we see that are transmitted through the pelvis. This has been nicely outlined in Freddie Deschamps' radiology publication, looking at the different screws that we can put in the pelvis to sort of support these columns of force. And this is just the various corridors. And so when we have a patient like this who has, significant disease, right? You have somebody who has two-column disease on both sides, we're going to need to do something fairly significant to stabilize this patient. And so in this patient, we would offer preoperative embolization because it was renal cell. We would do ablation, and in this case, microwave ablation because we have large tumors and we want the efficiency of microwave to be able to treat the lesions, and then a combination of screw and cement fixation. And this is actually, as we've evolved these techniques, people are looking at kind of the patterns that continue to develop. And this article that was published this year kind of talks about what they describe as the novel tripod construct, but it's really not novel. We've been doing this for years now. And so basically you create a tripod around the acetabulum and then reinforce it with cement. The tripod can have different configurations, as you can see from left to right, but basically that tripod is a strong construct around the acetabulum to prevent a protrusio fracture. And so this patient had bilateral hybrid ablation plus osteoplasty and screw fixation. And so I'll just kind of walk through this, but we use a special angiography suite with cone beam CT that's combined with a dedicated CT scanner. We use needle guidance software, and so we'll take the CT scan and we'll plot out the lines for our screws, for our ablation probes. We can also draw volumes where we want to deliver cement or do an estimation of what the ablation will look like. We have to register the patient once the patient gets into the room to the preoperative CT scan. And then we do what's called augmented fluoroscopy, where we use real-time guidance to place our guide pins, our ablation probes, our screws, and then inject our cement. And so in this patient, you see these lines that we're drawing on the CT scan. We then load these into the room, and we can actually use these to navigate our way to place the screws in the different corridors. And so here are just examples in that particular patient where we're drawing lines of trajectory to place the probes, avoid the sciatic nerve, estimate the volume of the ablation. We can place lines that will sort of outline the sciatic nerve that are projected on the screen, so we stay away from them, and we can plot the placement of the probes and advance and retract them using these lines and these X's to sort of help us understand measurements on live fluoroscopy. And so again, cement volumes can be estimated, tumor volumes can be estimated, and all of this is projected onto the screen. And so you can see these guidance lines on the augmented fluoroscopy that allow us to place our guide pins and our probes and our cement cannulas. And then what's nice is that as you rotate your II, you can actually see these move in real time, and you can then watch your cement as you inject it, and you literally just need to keep it in bounds, if you will. And so this is just, again, examples in that extreme case where we're using the lines to help us understand where the cement is flowing so that we can do it during fluoroscopy. So in this patient, it had to be a staged procedure. We did both procedures 7 days apart, but we were able to offer, in a relatively minimally invasive way, a major improvement in this patient's pain, ability to ambulate, and to get started on chemotherapy and radiation within 1 week after we finished everything. Another patient with renal cell, and you can see 72 years old, metastatic renal cell, had already had radiation, and I'll just sort of power through this for you all. Augmented screw reinforcement is what we planned, ablation, and then we had the sciatic nerve right here, so we were concerned about the sciatic nerve. So in this case, we used cryo, and this is our end result. But basically, again, we can place the cryo probes, we can trace the sciatic nerve, we can then convert over to CT and watch the ablation zone and keep the ablation zone away from the sciatic nerve. We can use temperature probes in real time to monitor the temperature, and we can watch the ablation zone as it propagates. And then literally under augmented fluoroscopy, we can place the screws and then deliver the cement, and you can see the final result there as we've injected the cement, and we get a nice result that then will allow the patient to get back to function. This is a final case. This is sort of the biggest case we've ever done. So you have a patient with cholangiocarcinoma, but they also have a metastasis to the hip, and it actually crosses over to the femur. You have, on the same day, we ended up doing a chemoembolization of the cholangiocarcinoma. We embolized the hip tumor. We then proceeded using the techniques that I've just outlined to place screws both in the acetabulum and in the femur. We did microwave ablation, placed the screws to support that defect, and you can see the microwave probe here in the femur for that femoral metastasis. We've already ablated the patient in the acetabulum. We've placed the screws. We've augmented with cement. And you can see pre and post what this patient looks like. This patient was treated in 2016 and is still alive today and was able to have chemotherapy and radiation immediately. And if I could get this movie to work, you could see what he looks like when I saw him in clinic.
I'll walk right by you.
So he's walking on that construct. Now that was several months out, but that is, a major improvement in his pain and his function. So we published this, and others have published this, and we showed minimal complications in our hybrid method versus traditional surgery. We were able to, allow them to have immediate chemotherapy and radiation. We had no infections, and their functional scores improved significantly preoperatively in both our arm compared to the surgical arm. And so many centers now are adopting this, including Dr. Kalikas's and Dr. Madoff's, and I'm sure our colleagues will talk more about some of the things that we can do in these patients. But, essentially this offers local tumor control, it's safe, and it's minimally invasive. It can be done nearly outpatient. It can be done single session, and patients recover quickly and can have their chemotherapy and radiation. So I'll finish there, and I got to unshare my screen, and I'm back.